Hello, everyone. My name is Xunming Li. I'm a medical oncologist at MD Anderson Cancer Center here in Houston, Texas. Today, I'm joined by two of my colleagues, Dr. Christine Argento, who is an interventional pulmonologist at Johns Hopkins, and Professor Albrecht Stenzinger, who is a molecular pathologist at University Hospital Heidelberg, Germany. Let me present my case to my colleagues first. Today, I'm sitting in my clinic, encounter a new patient referred by a community oncologist. This is a 81-year-old lady who never smoked cigarette. On the imaging, we have identified a pleural effusion as well as a lung cancer adenocarcinoma, tumor size primary at 4 centimeters, but with a lot of nodal involvement as well as metastasis to the liver. Therefore, this patient is staged at stage 4. She did not have brain metastasis by brain MRI, and her performance status is relatively borderline at performance status ECOG of 2. When she presented to me, in her initial workup package, other than diagnostic testing of the initial adenocarcinoma, as well as a complete imaging testing, a local team has already ordered liquid biopsy. The result, though, did not detect any mutation, so there was an empty detection. Now she is sitting in my office. I explained to the patient that molecular testing for guiding the initial selection of treatment for stage 4 lung cancer is quite critical. Then she posed to me, what should we do as the next step? I took this question to talk to one of my interventional pulmonologist colleague, Dr. Argento here, as I'm thinking between options of going through an interventional radiology approach to get the tissue, as the patient do have a liver metastasis, usually is accessible. However, patient also have significant nodal involvement by the CT and the PET scan. So Dr. Argento, for this particular patient, when I approach you, would you please give us some pros and cons for each approach and make your recommendation for this particular patient?
Sure. I think this is a really common scenario, something that we see quite often, where we have an individual who has clearly a metastatic process. So there's multiple, there's a pleural effusion, there's a liver lesion, a large mass, pretty significant nodal involvement. So you've got lots of targets. So the question is really going to be based on this patient, how can you do this? And there's lots of different options. You could easily get fluid by doing a thoracentesis from her pleural space, and that often yields enough tissue to get a diagnosis and sometimes molecular markers. However, sometimes in pleural fluid, the molecular markers are not always as attainable just because the cellularity tends to be a little bit lower in even malignant pleural effusions. The other option from an interventional standpoint would be bronchoscopy. And I would recommend something like EBUS, which is endobronchial ultrasound, where you can go after and sample either lymph nodes or the primary tumor. And there you should be able to get plenty of tissue to both diagnose and obtain sufficient tissue for molecular analysis. In contrast to the IR, where I think in this case, it would be absolutely reasonable to go after a liver biopsy, or alternatively, if it's easier, they could go after the mass, or they could do a thoracentesis as well and biopsy those with a transthoracic approach. There are a few pros and cons to that. Generally speaking, our interventional radiology colleagues really do obtain enough tissue with core biopsies to do the diagnosis and molecular testing. If you're doing a transthoracic needle biopsy of the lung, for example, you do have a slightly higher risk of pneumothorax and bleeding rates than you would with bronchoscopy. Both of us can do ultrasound-guided thoracentesis. And typically, we would suggest, if you see a patient in her case, to go after something that would prove she has stage 4 metastatic cancer. But in this particular patient, I would say she's got such overwhelming evidence of metastatic disease that maybe you don't have to do that if there's an easier approach to obtaining tissue. So I think you could really ask either of us. So whoever is available and can get the patient in sooner. Another of the things you just have to think about in this person who might be a little bit older and she has an ECOG status that's a little bit borderline, you may want to think twice before putting her under an anesthetic for a bronchoscopy. So that might be a consideration. However, giving her a pneumothorax or a bleeding complication may also be a consideration. So it's sort of 6 of one, half a dozen of the other. There are pros and cons to several of these methods.
Thank you so much. All right, so for this particular case, after I discussed with Dr. Argento, we discussed with the patient as well. We end up going the route of EBUS so that we can obtain adequate tissue. Quickly, the procedure was performed, and then the tissue has been sent to our pathology department. And then now I will need guidance from our molecular pathologist team in terms of which panel to use, what type of testing we want to do. And as a clinician, I know I need to do PD-L1 and then beyond PD-L1. So I want Dr. Zisinger's input about how can we quickly and accurately identify potential driver in this non-smoker female patient.
Yeah, thank you very much. Happy to help. I think the main point is probably that we are talking about formalin fixed and paraffin embedded tissue in many instances, meaning that a hybrid capture short read sequencing approach is certainly very valuable in this regard. Even though you could also use, ampli-seq based technology, that very much depends on, the necessities and your individual lab. But the most important point probably is that you know your technology and your assay very well. Secondly, I think it's important to sequence both DNA and RNA. The RNA is well preserved in paraffin embedded and formalin fixed material, so that you can read out the transcripts of, for example, gene fusions like ALK, ROS, RET. And it also helps you to infer transcripts that may stem from METex14 skipping mutations. On the DNA level, you want to make sure that your genes of interest are, well covered, including adjacent intronic regions. And lastly, there is, a tight interplay between tumor cellularity on the one side and on the other side, the sequencing depth over locus and the coverage of all of the genes you're interested in. So therefore, you really need to make sure that your sequencing depth is sufficiently deep. So for 30% chemocellularity, for example, you would want to have a coverage over locus, a read depth over locus of around 300x. And then you should be basically fine. The story is a little bit different when we are talking about liquid biopsy, but for tissue, that's probably the major aspects around testing.
Yeah, thank you very much. So basically, your advice will be at least perform DNA and RNA-based next-gen sequencing, and then the sequencing method itself might not matter as much because the technology has been evolving. As a clinician, one of the key questions I need to know is the turnaround time. So in this case, the moment I send the tissue to the path core, what's the time you expect that the clinicians will have the report? I know there are many steps in between.
Yeah, that's another great question. I mean, as we all know, the international guidelines around NSCLC testing would say that 10 working days are what you should achieve from a lab perspective. In Heidelberg, we are even below this, around 6 working days for a full report, including the DNA and the RNA side. Turnaround time is very much influenced by, because it is essentially a volume business, by the number of cases in relation to the sequencing devices that you have, the sequencing capacities. And secondly, there might be also a turnaround time part influenced by receiving the block material from some, outside hospital. Their, networks are probably quite important, so that you can retrieve samples and ship samples in an easy and fast manner.
Yeah, thank you very much. So to wrap up this case, after around 2 weeks of waiting, so that's 10 working days, we did receive the tissue NGS report. In this case, we received both DNA and RNA results. From the DNA, there is a acceptor mutation detected, and then from the RNA results, we had a fusion report, basically exon 13 to 15. So both strongly support that this tumor has METex14 skipping, happened at acceptor location and resulted in the METex14 skipping event. And this patient moved on to the targeted therapy treatment. So I want to wrap up the case and asking both of the physicians joining me today to give a one-liner about what's a highlight, what's a take-home for this particular case. So let me start with my interventional pulmonologist colleague, Dr. Argento. Please go ahead.
Thank you. Well, I think in this case, from my perspective, what's really important is being thoughtful about the patient, what they can tolerate, and making sure that you're doing a biopsy that's really going to give you all of the information you need, which means diagnosis, staging ideally, and enough tissue for molecular analysis. So we really need to make sure that that's available because it's really guiding your next steps in care.
Thank you. And Dr. Stensinger, please.
Yeah, I think combined DNA and RNA sequencing is really key in this regard, especially when you're talking about the genetic event that you were just mentioning before. And, second major point is probably know your assay well.
Thank you. And from the medical oncology perspective, I will just say a multidisciplinary approach is very, very important. The discussion with Dr. Argento as well as Stensinger is really helpful for guiding me through the case to get the appropriate report to help me to make a decision with the patient. Thank you very much. Hello, everyone. My name is Shuning Li. I am a physician. I am a thoracic medical oncologist at MD Anderson Cancer Center in Houston, Texas. Today, I'm joined by Ms. Stephanie McDonald. She is an oncology nurse practitioner practicing out of Dana-Farber Cancer Institute in Boston. And we also have Dr. Sandra Kohler, a clinical oncology pharmacist at the University of Illinois College of Pharmacy, Chicago, Illinois. In today's session, we'll discuss the management of patients with METex14 skipping non-small cell lung cancer. We'll start with a patient case today. In today's clinic, we had a female patient presented for treatment recommendation. She is 81 years old, have no prior smoking history. Her course was initially found to have shortness of breath, leading to workup identifying pleural effusion. Imaging study indicated not just pleural effusion, but a 4-centimeter tumor in the left lower lobe, together with metastasis in lymph nodes and bilateral lungs. Therefore, this patient is unfortunately staged at stage 4 non-small cell lung cancer. Her performance status by ECOG evaluation is around 2, which is very commonly seen in the elderly patient. For the diagnostic workup, we performed both tumor biopsy as well as liquid biopsy. Tumor biopsy confirmed adenocarcinoma. Liquid biopsy didn't detect any alterations in her blood. However, in the tumor sample, by RNA-based next-generation sequencing, her tumor indicates that she has a MET exon 14 skipping mutation, which is a established classical deletion mutation. I discussed this case together with my team. I wonder if, Sandra, you can give us some preliminary recommendation thinking through for a elderly patient's ECOG performance of 2 with metastatic MET exon 14 skipping lung cancer. Sandra, please.
Sure, thank you. And this is an amazing time to be managing this particular patient that has this mutation that really is only seen in up to 1 to 5% of patients. So this is not a mutation that we see commonly in non-small cell lung cancer, but now we have targeted therapies for this elderly patient. 5 years ago, we would have to offer probably systemic chemotherapy. But we have targeted agents that are listed here on the slide that target this particular mutation, this MET exon 14 skipping mutation. In the United States, we really have 3 options, oral agents that we can offer this patient, crizotinib, capmatinib, and tepotinib. So when we get we look at these treatment options, we think, well, which one would we select, right? And so when we think about crizotinib, one of its limitations is that it does not have CNS activity or penetration. So really we prefer the capmatinib or tepotinib. These are both MET exon 14 skipping directed agents. They're orally available. With an elderly patient, maybe something easier in terms of her taking this medication at home. When we look at which one, capmatinib or tepotinib, as you know, Shilan, both of these agents were approved based on phase 2 data. The phase 2 preliminary data was positive in terms of response rates and duration of response. The efficacy was pretty similar between these two, as well as their safety profile. Primarily grade 1, grade 2 adverse events that were manageable. So really we're whittling it down to capmatinib and tepotinib. And as a pharmacist, I would take it in terms of efficacy and safety are pretty reasonable. Then I look at that 3rd tier criteria, which is cost and convenience. Tepotinib is a once daily drug. So that's where we're kind of shifting and going to in that setting.
Yeah, Sandra, thank you so much. I just want to add that crizotinib, although we use it, but after tepotinib and capmatinib approved, I think in clinic, we rarely go back to the older drug because of toxicity, higher toxicity, inferior efficacy. I do want to point out that although we have 2 TKIs available in the United States, we have additional MET inhibitor available in other parts of the world. For example, savolitinib. There are times we see referral patients receiving that medication as well. So it's really a good thing for patients that globally there are many options here. Based on, Sandra, your summary, I would probably recommend to this patient and her family tepotinib because it's a efficacious TKI, very convenient once a day. So in the clinic, now we move on to the consent procedure, prescribe the medication to the patients. And then at the initial time of patient education, I think I will have to rely on Stephanie to start to set up the stage for ongoing monitoring, ongoing toxicity check and managing. So Stephanie, in this particular case, I think now your role become very prominent.
Yes. So right after the patient has the diagnosis, they met with their medical oncologist. We've chosen the medication that's best for them. Then I work with the patient to help kind of set the foundation of their journey and their care receiving this medication, in this scenario, tepotinib. So what I'll usually do is with my team, I talk to my medical oncologist, I'll then have the patient set up for a visit with me for chemotherapy education. And so I'll meet with the patient, we'll set aside about an hour, and we'll be able to really dive in deeper as to kind of what the potential side effects are, identify supports for the patient. What was standing out for this patient is their performance status, and not only their age, but they also have that left pleural effusion. So kind of educating the patient on potential symptoms to report, side effects. So also educating on the role of our nurse navigator, because I think the key to this drug is communication. So when things come up, like new symptoms of shortness of breath or leg swelling, we want the patient to really know who to call and how to get a hold of us and when to call. So for in this case, I usually, when I see the patient, I'll set up lab checks and in-person checks with the patient about every 2 weeks for about the first month, to check in on monitoring. Usually after I first see the patient, I'll have my nurse navigator call the patient about a week later just to do a check-in by phone. But I don't know if that's always reasonable in clinic. So just making sure the patient knows how to get a hold of us, even in community settings, depending on resources that are available, as long as the patient knows how to contact us. I think that's the most important thing. So most common side effects and things I would want to look out for is the effect on the liver function tests, the kidney function. So that'll be included with usually a complete blood count when they come in to see us every week. I'll focus in on a pulmonary assessment because there is a risk of interstitial lung disease with this medication. So making sure patients know to report any new chest pain or shortness of breath, because that's going to require more of a workup, and having them come into clinic to rule out other causes, which are common with patients with lung cancer, right? A risk of lung infection. She has a known left pleural effusion in this case. So is the fluid reaccumulating or building? And does she have possibly a pericardial effusion? Those are potential things that our patients could have as possible effects from their lung cancer. Is there the inflammatory component? Or in our patients, as you know as well, could be at risk for pulmonary embolism. So ruling out and doing a good pulmonary assessment is key. As far as GI side effects, making sure we have a good plan for nausea for these patients. Usually I'll look at other medications that they're on, and we'll prescribe maybe compazine or prochlorperazine or ondansetron just preventatively for these patients. Having them report signs of liver toxicity, which might be uncommon. You might see it on lab work first, but if they're having any signs of jaundice or dark urine or abdominal pains, they want to be reporting that as well to us. Low albumin will be following on lab work. I would say I want to just key in on the most common side effect associated with tepotinib, which would be edema. And about, you can correct me, Dr. Lee, I think maybe 55% of patients will have, with most of these MET inhibitors, will have some form of swelling. And it's not easily manageable. So it's going to be difficult to manage. They don't always respond to diuretics. And especially we need to consider our elderly population and looking at their other medications that they're on, other comorbid conditions, and just be watching them really closely. If we are trialing diuretics, we need to be educating them about watching their blood pressure, changing position slowly because it could increase their risk of falls. And honestly, I haven't seen much benefit with diuretics in these situations because of the mechanism of action from these drugs. So usually I rely on a multidisciplinary approach with these patients, working with physical therapy, a lymphedema clinic if we have that available, to help with compression stockings, leg elevation, and they ultimately may require a dose reduction in these cases. So that would be my approach as far as kind of our first visit, but that it's overwhelming at the first visit. So we reinforce this education every time we see these patients, working with my MD colleagues and my nurse colleagues to try to reinforce this education and just a holistic multidisciplinary approach for these patients.
Yeah, thank you so much, Stephanie, for this comprehensive review. I'm sure after this conversation, the patients and the family felt they're fully supported. They have a way to reach out to the medical team. The medical team is on the lookout for potential toxicities, and for each of them, you provide a very clear, concise way to help to mitigate. This is extremely helpful. So I will come back to Sandra. Can you please just provide us one line of wisdom about the MET TKI, when you're selecting them, how you're recommending to the physician and the family, just provide one line of wisdom for us.
Yeah. So again, I think that capecitabine and tepotinib are both have similar efficacy and similar side effect profile. So really selection becomes on maybe convenience or even toxicity. As Stephanie said, edema is a class effect of both of these agents. Edema is something that is a reversible adverse event, withholding and then restarting at a dose reduced. I agree with her that diuretics are really not, we haven't seen any big benefit there, but compression stockings, elevated limb, sometimes holding, and then restarting a lower dose does seem to work. And there has been even a case report where even switching them, where it's switching one from capecitabine to tepotinib, and then reducing the dose kind of worked. So there are some case reports out there to help us manage, because we really think that these drugs are quite beneficial in this patient population.
Stephanie, how about you?
Yeah, I think the key is communication with the patient and the primary team, a multidisciplinary approach, and just make sure the patient feels well supported. It's a scary starting a new treatment, and we want to make sure these patients know what might come up from time to time, what to look out for, because I think the key is prevention and early identification of symptoms and side effects, so we can get on top of managing these patients to not only help with their cancer care for, primary treatment of their cancer, but, a holistic approach, making sure that there's quality of life for these patients and that they're tolerating these treatments and able to continue to do the things that they want to do. So that would be my take-home message: communication with your team.
Yeah, thank you. From my physician perspective, I want to say that METex14 now have 2 TKIs. Their efficacy, each of them are excellent in response rate greater than 50% for all the patients, and progression-free survival around 8 to 12 months. So I will encourage patient, physician, and the family, don't be intimidated by the toxicity, because the clinical efficacy is really beneficial for those patients. But rely on the multidisciplinary team approach so that patient can derive both clinical benefit and avoid those toxicities. Thank you very much. Hello, everyone. My name is Xiongning Li. I'm a medical oncologist at MD Anderson Cancer Center here in Houston, Texas. Today, I'm joined by 2 of my colleagues, Dr. Christine Argento, who is an interventional pulmonologist at Johns Hopkins, and Professor Albrecht Stenzinger, who is a molecular pathologist at University Hospital Heidelberg, Germany. In today's section, we'll be discussing a case with MET amplification in EGFR TKI refractory disease. Here is my clinic. I had a patient who had been seeing for actually a couple of years. This is a 77-year-old male who had a prior smoking history. About 2 years ago, the patient was diagnosed with stage 4 lung cancer. At that time, we detected EGFR deletion 19. Therefore, the patient received upfront osimertinib for about 2 years. In the recent interval, basically in the last 2 to 3 months, the patient started to notice increasing coughing and some shortness of breath. At the time of restaging scan, we did detect that the primary tumor started to enlarge, as well as associated mediastinal lymph nodes and hilar lymph nodes. In this particular patient, by the CT scan, the tumor size has enlarged to about 20%. Therefore, I had a discussion with the patient of potentially disease progression. One part that's important for managing TKI refractory EGFR mutation non-small cell lung cancer is to understand if there is a secondary genetic driver, because we potentially have newer medication and the combinations to help this patient population. If the tumor has no genetic driver, the patient's resistant driver, then the patient's next option will be chemotherapy-based or other investigational trials. To understand the molecular resistance driver, I send off the liquid biopsy. That's a relatively very non-invasive approach. However, I do also want to obtain tissue. One reason is to rule out the small cell transformation and the squamous transformation. The other is to have the tissue for a tissue-based NGS testing. Today in my clinic, I want to discuss this case with my interventional pulmonologist team to see the feasibility and the safety of a EBUS potentially for this patient. Therefore, I walk over to Dr. Argento. Dr. Argento, for this case, can you please review with us about the potential pros and cons of different tissue acquisition modalities? And for this particular case, do you have your recommendation?
Yeah, thank you. I think this patient, for me, is a pretty clear pathway towards endobronchial ultrasound or EBUS, because not only has the primary tumor enlarged, but so have all the associated lymph nodes in the chest. So EBUS is really an extremely safe, quick, easy way to obtain tissue that is going to be really good to look and see, has there been any transformation as far as the histopathology of the tumor, as well as to obtain additional molecular markers so that you can send off NGS testing and make sure that there are no driver mutations that are affecting this progression of disease. And so I think the one good thing in this case is that EBUS is repeatable. So you can do EBUS over and over again as needed as these patients progress and they wax and wane. Sometimes when they're on therapy, their lymph nodes and even their primary tumors can enlarge, and then they can eventually recede depending on how things are going. But often this does need, unfortunately, means that there is progression of disease. So I think the biopsies are, generally speaking, very high yield, even in patients who have been on therapy for several years. Even if they've had other things like radiation therapy, for example, may cause some fibrosis of the lymph nodes or of the primary tumor, which may cause the sample to be a little bit less cellular than it would have been originally with biopsy. But if we have our cytopathologist or pathology colleagues in the room with us, that's called rapid on-site evaluation, or ROSE, they can often let us know, give us feedback on our sampling in the procedure to make sure that we have enough cellularity to do all the testing that we need. And that makes sure that our bronchoscopy is going to be a one and done. So your patient doesn't have to come back for multiple procedures, multiple forms of biopsy. You should be able to get all of the tissue you need for all of the testing you require in one setting.
Thank you. Thank you very much. So in this case, since you strongly recommend the EBUS, I also felt that's a procedure that we perform a lot in the high volume centers. So the patient proceed with EBUS biopsy, and his tissue, of course, detected malignant cells and were sent to the core for additional testing. So here, I want to hand this case over to our molecular pathologist, Dr. Stenzinger. So as a clinician, I would like to know, first of all, how quickly I will know the histology report and how quickly I will have the NGS if there's no transformation so that I can make a clinical decision. Of course, what type of testing you will apply for this particular case.
Yeah, thank you. I mean, the turnaround time for rendering an initial diagnosis, this case, non-small cell lung cancer, adenocarcinoma of the lung, that is usually a turnaround time, depending on the lab, between 24 and maybe 48 hours. Some institutions may be even faster. With respect to the molecular testing, a combinatorial approach using liquid biopsy and tissue-based testing, could make sense. for tissue-based testing, RNA and DNA sequencing is very much needed, simply because on the DNA level, since most of the assays that are being used are panels, intronic regions might not be well covered. And so breakpoints, that give rise to fusions might not be adequately covered as well. And the RNA side would give you the fusion transcript, so that can help quite significantly. Depending on your setup, you can also detect, high-level amplifications very nicely using a panel-based next-generation sequencing approach. On the liquid biopsy side, things are a little bit more tricky. Remember that, RNA-based sequencing from blood is not something that is routinely used in daily clinical care. So most of the panels out there are on the DNA side, and then you really want to make sure that your DNA regions, including those for the big breakpoints of gene fusions, that these regions are really well covered. Also, there are differences in terms of shedding of tumors. Different tumor types shed differently, and also depending on the tumor stage. And that very much influences your, sensitivity and specificity issues. Last point for liquid biopsy, you really need deep sequencing. So in Heidelberg, we run these with 10,000x over locus, as compared to maybe 300x when it comes to tissue. The reason being that sometimes the amounts of positive molecules, those with a lesion, can be really small. And very last point, molecules that aren't there cannot be sequenced. So it's very much influenced really by the shedding aspect and the number of molecules that you detect in your cfDNA.
Yeah, thank you for the detailed explanation. So based on your guidance, we send out for both RNA and the DNA-based sequencing. And like you said, 1 day later, we know that these patients still have adenocarcinoma, no transformation. And about 1 week later, we received liquid biopsy results. We still detected EGFR deletion 19 truncal deletion mutation, but didn't have any additional alterations in the liquid biopsy. At this time, I turn to you, of course, sending emails asking when the tissue results going to be back. In this particular case, will you recommend us to wait? Clinically, the patient is quite stable, although have some coughing, but it's been going on for more just at the baseline and a slow progression disease. So do you think there's still additional value to wait based on the no transformation, based on relatively no driver mutation detected in the peripheral blood?
Thank you. Refers back to what we discussed before, a question of molecules that aren't there cannot be sequenced, right? And so it can well be that in a liquid biopsy specimen, some event goes undetected because the molecules harboring a certain genetic lesions are simply not present in the amount that is needed in terms of your assay sensitivity. So having both, the tissue-based data and the liquid data can be very helpful. And as you say, if the patient is stable and we have some more time, I would recommend doing so.
Yeah. Thank you so much. So we, as a team, decided to wait. Of course, patient is a part of the decision-making team for the complete tissue NGS report to return before we make next step clinical decision. Another week passed by, we did receive the report from our molecular pathologist team that the tumor has MET amplification at very high copy number greater than 10. So in this particular case, we identified a resistant driver for this EGFR TKI refractory tumor, and therefore we start to think about downstream. The treatment option can be dual inhibition of EGFR and the MET pathway. So in this particular case, the patient end up going on to a double TKI inhibition. But I think for this discussion, we just highlighted the importance of trying to understand the resistance mechanism. We will give our tradition. I will turn to our colleagues today just to give us one-liner summary about in this TKI refractory situation, no longer newly diagnosed, what's your advice for physicians and the patients? So I'll start again with Dr. Argento, our interventional pulmonologist.
Thank you. I think in this case, it really highlights well the importance of making sure to really investigate what's happening in these patients and do that with an additional biopsy to make sure they haven't transformed and to be able to look at your NGS panel for additional driver mutations that will be able to help and guide treatment. From my standpoint, EBUS is extremely safe. It's able to be repeated time and time again. So whenever the patient needs additional tissue, this is a really good option that is effective whether the patient has been on therapy already or not.
Thank you. And Dr. Stensinger, please.
Given the heterogeneity of any solid cancer and non-small cell lung cancer as well, combinatorial approaches in terms of testing can make a lot of sense, as we've seen here. Combined sequencing of the tissue, most recent tissue plus a liquid biopsy can be very important. The one point that I'd like to point out again is really that molecules that aren't there cannot be sequenced, and so even though liquid biopsy technologies can be super sensitive, they are very much influenced by the number of molecules per locus that you are detecting, and that is simply important to keep in mind. In other words, there can be false negative results even though a genetic lesion is biologically present and also druggable, and therefore the combined view, including the tissue side, can make a lot of sense.
Yeah, thank you very much. I think that concludes our day. Thank you for your attention. Hello, everyone. My name is Xuning Li. I'm a thoracic medical oncologist at MD Anderson Cancer Center here in Houston, Texas. Today, I'm joined by Ms. Stephanie McDonald. She is an oncology nurse practitioner at the Dana-Farber Cancer Institution in Boston. And we also have Dr. Sandra Kuller, a clinical oncology pharmacist at the University of Illinois, Chicago. In today's section, we'll be talking about MET targeting strategy for EGFR mutation non-small cell lung cancer patients who are refractory to EGFR TKI. We will start with a patient case. Today in the clinic, we have another patient come back for routine follow-up. This is a 77-year-old male. He is a former smoker. He has been in my clinic for about 2 years. At the very beginning of the diagnosis, there was a 5-centimeter lung mass identified, and the biopsy showed adenocarcinoma. At that time, he had distant metastasis, and the DNA testing indicates an EGFR exon 19 deletion. He has been seeing me for about 2 years because he was placed on osimertinib for the whole duration. He had a very good response initially. However, in the last couple of months, he started to have progression both in the primary location as well as in the metastatic site. Because of that, we performed a CT scan. We also performed the biopsy to understand what is the resistance mechanism to the EGFR TKI. Today, he's back to the clinic because our NGS testing is returned. In my last clinical discussion, we talked a little bit about potentially start him on chemotherapy, carboplatin with pemetrexed as a standard of care if there's no driver detected to correlate with resistance. today when I sit down with the patient, we did have the biopsy report showing a MET amplification, very high copy number at 10 copy number. Therefore, I first have my discussion with my team before I approach the patient. Here, I talked to our clinical pharmacy team, Dr. Sandra Puri, about the copy number MET amplification at 10. Sandra, can you deliberate on some of the options this patient might have with this new biomarker detected resistance?
Yeah, thank you. Absolutely. And as you know, Dr. Lee, when we send these next generation reports, sequencing reports, it's like we're on pins and needles, right? Because it takes about 2 weeks to get this result. And we're hoping that there is a targetable mutation. And especially in the second line setting, sometimes that there isn't anything, we have to go straight to chemo. But fortunate for this patient, we did detect, or there was a detection of MET amplification. So here, again, our options are, now we have more options than just systemic chemotherapy. We have amivantamab, which is a dual bispecific systemic treatment. And we also have data where we can maybe add touchIME, which does have data with MET amplification in combination with an oral EGFR agent. So I think here we have two options. We can do oral, targeting both mutations, or we can do it IV, systemic with amivantamab. So I would like to see what are your thoughts on which direction we would go to, again, knowing that this patient is 77 years old, previously on oral therapy. What are your thoughts, Dr. Lee?
I think I probably prefer oral, and then not just because it's dual targeting, but I think it's also for the convenience of the patients. So Sandra, touchIME, do we have once a day dosing? So if that's the case, patient can just simply add a pill to the OC, right?
Yeah, so touchIME would be two tablets, 450 milligrams once daily with food. So that would be something, that we could add to the osimertinib, with multidisciplinary team of a nurse practitioner, specialty pharmacy, clinical pharmacist, really sitting down with this patient, making sure that adding an oral agent to his medication treatment plan would be something that this patient would be able to do, along with treatment diaries, pill reminders, that this is something that hopefully would be easy for the patient to do.
That sounds actually very appealing, because if we have to go, so two reasons. One is after progression of dual oral medication, we still have the opportunity for the patient to receive IV treatment. The other will be simply adding a pill will maximally preserve the quality of life for this particular patient. Of course, when all of us are sitting in the physician room, Stephanie, I will have to rely on you to manage the dual TKI toxicity.
Yes, I think it is a all hands on deck approach, especially when you're adding two separate oral medications, because although the efficacy might be higher, the toxicity profile is higher as well and more extensive, especially knowing the mechanism of action for each of these drugs when given in combination. We definitely have a lot to educate the patient about and a lot to monitor to safely provide excellent care for this patient as they're on this journey. So I'll bring this patient into my clinic and provide education in a one-to-one session, introduce them to the role of our nurse navigator so that they can communicate when issues arise, and really hone in on the importance of calling us early, not waiting until maybe some symptoms are out of control or they're really not feeling well, to really kind of lean on us, know when to call at the first sign of maybe a potential side effect. So when you're giving these two drugs in combinations, you have to be monitoring for the EGFR potential side effects and the MET inhibitor side effects. So when they're coming into my clinic for monitoring, we're going to be checking baseline labs and monitoring for QT. You can have QT prolongation from the osimertinib. And so we want to be monitoring that at baseline and periodically throughout treatment. So usually I'll get that at their first visit and then about 4 weeks later, and sometimes 2 weeks later, or depending on their history, how frequent you're getting it. Monitoring their kidney function is very important in these scenarios, as well as electrolytes that could be altered throughout the course of treatment. I would say as far as education, if they've been on osimertinib already, they're probably well-versed, but just reinforcing the importance of calling with, rash or new shortness of breath, new chest pain or shortness of breath, the importance of management for diarrhea, especially on these treatments, and calling for any fevers or infectious complaints. And then again, honing in on the importance for the tepotinib portion of the drug, which can cause the edema and swelling. So again, just educating them on elevating their legs. We can utilize compression stockings, but first it's important for them to review and rule out other causes of leg swelling. So making sure they don't have a blood clot or an infection like cellulitis causing the leg swelling. So I think, again, it gets to the importance of a multidisciplinary approach, utilizing, our physical therapy team, our pharmacy team, our dietitian team, and really educating the patient on calling us for any potential side effects throughout their journey, so we can just be on top of identifying and managing any potential side effects that they have, so that they can safely continue on such an effective treatment.
Yeah, so with this conversation with my team, both with my PharmD as well as with my nursing team, I feel very comfortable and supported to talk to the patient about the dual TKI as our preferred regimen. From the INSIGHT 2 trial, we learned that osimertinib together with tepotinib can render a response as high as 50% and progression-free survival 6 to 8 months, depending on the copy numbers. So that I feel very comfortable starting with this patient. As a physician, I do want to highlight that in the EGFR TKI refractory space, we have seen a wave of clinical trials having very promising readout, potentially can change our landscape even further. For example, we start to see MET targeting ADC to have good efficacy. We also start to see EGFR refractory patient chemo in combination with PD-1 and VEGF inhibition also have very good efficacy in prolonging PFS. And the HER3 targeted ADC is also very promising. One last thing I want to add is for the biomarker, we no longer just think about next generation sequencing. We also start to think about cell surface. So IHC based for this particular case, I will ask my team to order the MET IHC in preparation for the next line of treatment. So as our routine, I do want to ask my team to have one line of highlight for this particular clinical case. Sandra, please go ahead.
Yeah, so I think that the take-home message here is, 2 oral agents targeting 2 different driver mutations has been investigated and demonstrated to show both safety and efficacy. Making sure we talk to the patient about the unique side effect profiles of each individual drug, and dose reductions would depend primarily on which adverse event the patient is experiencing, but this is something that is doable and is convenient for the patient.
Yeah, I agree wholeheartedly. I think the key to this, pursuing this dual treatment, is communication and education, and making sure the patient has the resources that they need to be able to safely continue on treatment. And if symptoms come up, they know how to get a hold of us, and we're checking in with them frequently, not only maybe by phone, but regularly, maybe every 2 weeks, especially as they get started on these drugs, to make sure that it's safe. And then we're balancing the efficacy of treatment and their quality of life, and making sure they have all their resources in place to help set up for success and to support them along their journey.
Yeah, I just want to say the precision oncology is moved forward such that we can do dual targeting not just the primary TKI, but also adding a secondary TKI in a safe and effective manner. And going forward, we'll have more options for this patient population. Thank you for your attention.